Welcome to the Screenside Chat at Children with Diabetes. Today's chat is with Dr. Graham Ogle from Sydney, Australia. He is a pediatric endocrinologist, works at Diabetes New South Wales, and is world renowned for his work as the general manager of the Life for a Child program, which provides resources to children and young adults in under-resourced countries so that they can care for their diabetes. And with that, I'm going to hand this over to Graham. I will come back here to help address questions after his presentation. Graham, you can take it away.
Oh, well, thank you, Jeff. It's a pleasure to be here today. Now, I think it's afternoon for most of you. It's actually 7 o'clock on Monday morning in Sydney, Australia here, and I can tell you that it's going to be a nice warm day, at least over here. It's a delight for me to speak to you. I went to one of the CWD conferences in Orlando a few years ago and had a lot of fun. And Jeff and others in CWD have been a wonderful supporter of Life for a Child over the years. So the Life for a Child program, this image here is an image that we just recently received. We run a competition every couple of years for the young people that we support around the world. And this is one of the entries that came in from Bolivia of this young lady expressing the tightrope that she feels that she's walking every day. And I'm sure many of you feel the same way. And this is a quote from the previous competition, which I think from a young lady in India, which I think says it all. I'll just let you read it. In Australia or in America, we have the resources to, the families and the young people with diabetes have the resources to manage their diabetes properly. Sometimes there's struggles, but on the whole, these resources are available. But in less resourced countries, they're often not available, and it becomes almost impossible or impossible for the families to be able to provide the resources. We did a survey a few years ago looking at 71 countries, and we asked some simple questions. Could the government provide insulin for old children who need it less than 15 years? And of the 19 low-income countries we surveyed, none of them could, and only 2 of the 18 lower middle-income countries were able to provide insulin. For test strips, which in these countries are paradoxically often more expensive than insulin on a daily basis, no low-income country, and no lower in middle income countries. So 37 countries, over half of the countries we surveyed could not provide test strips, even 2 strips a day. And the situation for glucagon was even worse, with it essentially being almost unknown. And we set the bar very low here. We asked, did at least 5%, not 95%, but did at least 5% of the families have access to glucagon in your country? And hardly any did. And the cost of care can sometimes exceed the average family income. But just basic care, human insulin, 2 strips a day, syringes, and 4 A1C tests a year can sometimes exceed the average single income. And these families have to make choices. Do they, painful, terrible choices. Do they look after the child with diabetes, or do they send all the other children to school? Do they look after the child with diabetes, or do they feed the family properly? It comes down to those sorts of decisions sometimes, which is just terrible. And in my travels, I've met various families, various young people. This is a picture I took in Zimbabwe a couple of years ago. And this lady has one child. She had another child as well, but that child died of being able to, not being, also had type 1 and wasn't able to access insulin. And now this young girl is able to do that and to live a normal life. This is a young fellow I met in Tajikistan, in Dushanbe, and he already had early complications in his eyes, in his kidneys, in his skin, because he didn't have access to care when he was young. And a young university student in Bolivia who was already heading towards, or already had significant kidney damage and heading towards dialysis for the same reasons. So because of this, because children were dying and because children were getting sick very early, decades and decades, before the lifespan that they should be living, in 2000, we commenced the program Life for a Child with the vision that no child should die of diabetes. And the program essentially aims to support the best possible care that we can in a given circumstance. We support young people up until the age of 26 years. And I think the key thing is that we work by strengthening existing diabetes programs. We don't start, you won't go anywhere and see a Life for a Child clinic. You'll see a Diabetes Association clinic or a government clinic or a mission hospital clinic or whatever it is. And there might be a sign there saying supported by Life for a Child. It's important to work with what's already there and to find the local champions there, the dedicated doctors and nurses and patient advocates and parent advocates, and work with them so that the program is sustainable. And we also conduct clinical research and international advocacy, and where possible, help both the young adults and also the recipient centers with achieving sustainability. So currently we're helping over 22,000 children and youth. I think it's close to 23,000 now in 43 countries. And you can see that countries are listed there. There's a lot of ones that you might expect to see there. There's a couple of odd ones. We do help in North Korea. It's pretty cool. We send American insulin, donated American insulin, across the ocean, actually in a refrigerated shipping container, because the carriers where there's not much air freight going in for America, and it's greatly appreciated. I remember I met the doctors there. I've met them a couple of times, but at one conference I met them, and the first time, and they come up to me and said, Dr. Graham, thank you so much for the insulin. The children are now well enough to go to school. And that firstly really touched me, and secondly, it actually encouraged me, because when you send insulin to North Korea, you think, well, is it going to get to the kids, or is it going to be used by someone else or whatever? But it was clear from that comment that it was getting through to the kids, and these kids were so under insulinized, just hanging on, that they couldn't even go to school, and now they can. And we're working with the Diabetes Association there to further improve care. There's a long way to go. We also help in lots of countries in Africa, as you can see, a few countries in the Caribbean and South America, in Central Asia, and then in South Asia as well. So the support we provide depends on the needs and depends on our resources, but we send insulin to I think 28 or 30 countries, meters and strips into more countries, syringes, and we help with A1C testing. We help many countries with complication screening, particularly with detecting early renal disease. And we help a lot with education, with both patient resources and also education of health professionals. We help with first camps. We've helped with first camps in a number of countries. And then there's other support that goes in, assistance with transport costs and communications in big countries, with capacity building. We do a lot of technical advice and mentoring, and twinning relationships are set up, and also a lot of research which is related to our mission. This is the team in Sydney, myself, Harry Kramer, and Rachel Clayton, who are in marketing and fundraising, Annabelle Ung, who's our logistics officer, logistics and finance, Jayanthi, who's our research officer, and Cecile Eigerben, who's a diabetes educator, who manages the education program. And then we have Emma Clayton. Emma's actually from America. She's from Los Angeles. She was diagnosed when she was 7 with type 1 diabetes. But then after university, she moved to the UK. And Emma is our health systems expert. And they're a wonderful team. I can't speak more highly of the team that I have. Everyone works really hard and is just brilliant at their jobs. We have an international steering committee. Stuart Eastwood is my boss, the CEO in Diabetes New South Wales. Julia von Oettingen, who's a brilliant young pediatric endocrinologist in Montreal. Dana Lewis, who many of you would have heard of, who's involved with the DIY pancreas movement. Kelsey Grodzowski from Direct Relief, an NGO, logistics and pharmaceutical supplies NGO in Santa Barbara. Stefan Basanson, who works in Mali and Africa. Ragnar Hannes, who many of you would have heard of, is a pediatric endocrinologist in Sweden. And Mark Barone from Brazil. Mark has type 1 also, and he works in with health NGOs there, and is on the board of the International Diabetes Federation. Our major partners and donors are Diabetes New South Wales, where I work in Australia, the Helmsley Charitable Trust. I'm sure most of you have heard of the work that the Helmsley Trust does in research and in improving care, and they've been a wonderful supporter of us for over a decade now. JDRF also help in this as a substantial donor in the same way as Helmsley do, and then Diabetes Australia. And then we Direct Relief, I mentioned in Santa Barbara, ISPAD, the International Society for Pediatric and Adolescent Diabetes. And we work closely with Insulin for Life, as many of you might have heard of them as well. They collect unused supplies in the community and from hospitals and send them out to countries. And we've always worked closely with them. And major donors, Lilly give us essentially all the insulin that we need. We have to work out how to get it into the country and ship it, although Lilly do help with the shipment costs as well. We just have to work out the logistics. Trividia, based in Fort Lauderdale, help us with meters and strips, as do LifeScan. Becton Dickinson provide the syringes we need, and Siemens help with discounted HbA1c testing. And we really thank these companies for this support. And all this support is provided no strings attached. None of these companies have ever tried to direct us into any particular countries or to use this in any particular adverse way. They really have supported our program well. And we have very many individual donors, including people associated with CWD, and we're very grateful to all of them and all of you. I won't read through this, but we have many academic partners as well. And then we collaborate with Marjorie's Fund and Team Type 1 and others. And various NGOs in various countries. You can see Luxembourg, Sweden, Netherlands, UK, the ADA, and various others, DECA. Rotary have been a great supporter over the years as well. And in particular, in the middle there, you'll see in red, the diabetes online communities. And this connection came through Giles Renfro and through Jeff and through others. And Kerry Sparling's been involved for a long time, Kelly Close and others, and Manny Hernandez and others. And this has been a wonderful connection for us because of the enthusiasm and what the DOCs have introduced us to other people, to people who want to help with mentoring, who can help with resources or with funds or whatever. And it's been a super connection, and we're looking forward to develop that further, because as you might imagine, in these countries, they have their own little groups, WhatsApp groups or whatever, and being able to link them in with a wider group is a good thing. And one of the initiatives is Spare Our Rose. This is an initiative of the Diabetes Online community, and it was started by a group including Jeff. And in fact, Jeff was the prime mover at the start there. And every year on Valentine's Day and the days beforehand, there's a campaign to raise funds for Life for a Child through the Diabetes Online communities. And it started in 2013, as you can see, and the amount of funds raised has gone up each year. And last year we had over 73,000 come in from 822 donors in a bunch of different countries. And it's interesting as the program grows, how quickly it can expand around the country. An example is Rwanda, where we started in the capital, and the doctor there, the Health Diabetes Association there was so encouraged, they went to the second city and it started there. And within a few years, it was helping all over the country. And now it's very promising. The government's providing most of the insulin that's needed, and they're starting to take over the care as it moves along. In Ethiopia as well, we're helping in all sorts of different sites. And this is actually an old slide. I could put in a few more stars in some other places that I know where we're helping now. Education is critical, and I think this gives an example. This boy wrote that his first treatment was given by a child specialist, and he was getting mixed insulin twice a day, which is something, but it isn't what he should be getting. And he was getting his blood glucose checked once a month from a laboratory. So there's a number of things wrong with this level of care, as you can see. Firstly, it'd be better if he was on other types of insulin. Blood glucose testing once a month is almost useless, and the doctor's making a lot of money from getting the family in to do the injections. It's disturbing. So what we did is we developed guidelines. Now the ISPAD guidelines are the global guidelines really that pretty much everyone uses, but they're too long. They're very they're great for a first world setting, but they have all sorts of ins and outs and everything. If you're a doctor or a nurse in a less resourced country and you have a child dying in front of you with diabetes, you want to know, what do I do first? What do I do second? You need almost like a cookbook, a recipe book. Do this, then do that. If that happens, do this. And so with ISPAD, we developed that into a pocketbook, and this has been translated into a number of languages now and made available. This is another example of the need for education. This boy in Nigeria, a girl in Nigeria, when it started, it was just funny. You had to go off to the toilet. Everyone was laughing at her, and then she got sick, and then she went to hospital, and she stayed in the hospital for months because no one really knew, well, teach the family how to give the injections. And you can just imagine the discussions in the hospital. Someone probably said, well, let's teach the family. And one of the other nurses, the doctor said, oh, you can't do that. I have to come here. And then they thought, but they do it overseas. And then someone said, okay, well, we'll try it. And sure enough, as soon as they taught the child to do the injections, the family went home, not surprisingly, as I'm sure you all would know. So we have education resources in many different languages on our website, and this is being expanded now into other languages. There's a comic book, a graphic novel, which was first written in French in Congo, in Kinshasa in the Congo, by Dr. Marguerite de Klerk, who's now 93 years old and still working part-time, a remarkable Belgian nun. And she wrote this book with some people with diabetes in the Congo. It's such a good book that we've translated it into various languages. The Rwandan government even paid for the printing within Rwanda. And these sort of resources, just as I'm sure your family's found resources which have connected with your child or your teenager, or however old they are, these resources are needed. Same with a video, Professor Bumblebee. It's this very simple video done almost 20 years ago now has been downloaded well over, I think, 150,000 times in different languages on YouTube. There's particular needs as well. This is when I was in Khartoum in Sudan. I was taken by Mohammed Abdullah to meet this family. It's the boy with the white cap who has type 1. And they were squatting in a house with permission, a half-finished house with permission of the owners, and they had no electricity. And it's hot in Sudan, particularly in summer. And so this is where he stored his insulin. He didn't have a refrigerator. And so this is a clay pot filled with water, and the water's dripping down into this smaller clay pot here, and his insulin's in a plastic bag in there. And this is the only way to keep his insulin cool was through evaporative cooling. And this system, in terms of different size clay pots and other cooling devices, is used in many countries just to try and keep insulin cool when you don't have a refrigerator. So we sent Michael Sorensen down to Khartoum. Michael's he's now a doctor. He was an IDF young leader at the time. He has type 1, and we got clay pots from 7 different countries, flew them into Khartoum and tested them to look at their efficacy. And this is the temperature. This is the ambient temperature, so the room temperature. And you can see all the devices were better. This is over 24 hours. All the devices we tested were better than the room temperature, and some were better than others, achieving quite a big drop in temperature down towards room temperature, which is what we wanted, or better. And we also tested the Frio bags that you can buy. And there were 4 devices that had the most, the top 4 couldn't quite be separated statistically, but the top 4 included the Frio bags, but only if you were suspending them, 2 of the clay pots, and a goat skin. Now, this might look a little bit impractical, but it works. So the water, this is a clean goat skin, and then filled with water, so it sags, and probably 2 different, maybe, no, I think it's the same goat skin, and the insulin's kept in water. Now, this is obviously a pretty way out sort of thing to do, but of those 4 devices in the top group, this one actually had on numbers the most effective cooling because of the large evaporative area. But where there's a will, there's a way. And so one of the things we're working on is trying to get the companies to release information on thermostability of insulin, so we can understand when these devices are needed and when they're not. Another problem we believe, and I think the commonest cause of death of young people with diabetes in less resourced countries is they're just not diagnosed properly when they develop diabetes. So you all know the story of you eat too much and you drink too much, and then you get sick, and if it isn't picked up, you get ketoacidosis. And then you're breathing quickly, you've often got a fever because it's been triggered by an infection, you're dehydrated, and that diagnosis is often missed. And sometimes it's missed completely, and kids get diagnosed with malaria or typhoid or HIV or gastroenteritis or pneumonia or appendicitis or all sorts of things. And they just die rather than being treated properly. And this boy, Ray, who was 17 when this picture was taken, he wrote this. He talked about his diagnosis and how he started to get sick, and he was suddenly quiet. He had so many treatments, and then he was getting teased. He was getting punished by his father, and he was getting sicker and sicker. And then he got weak and went into ketoacidosis. And then finally, but at least it was made, otherwise he would have died, the diagnosis was made. So we've developed this poster with the International Diabetes Federation with pictograms, drinking too much, bedwetting, which can happen in younger children, return of bedwetting, and all the signs of diabetes, including being very sick. And this is the poster for Bangladesh, I think, but we've done this poster in many different languages, and because it saves lives. So our vision is moving on from keeping children alive to keeping them healthy, with reducing complications, preventing them if possible, emphasizing education and sustainability of both for the young people and the diabetes services. Now, everything went a bit haywire this year, like it has everywhere with COVID. This has been the year of COVID, and there's been extra needs and extra support that has to go out. This is a young boy in Guatemala with some supplies that were sponsored by Life for a Child for his family to keep them safe. We've published on this, and there's another couple of papers in the works. All our countries got hit hard by lockdowns, but in these less resourced countries, families who were often struggling with enough to eat people lost jobs. People couldn't afford the food prices as they went up. They couldn't get, the insulin wasn't being distributed properly. They couldn't afford to go to where the insulin was. All sorts of things were happening. And that's just the start. We're worried about the impact on health budgets now, because all economies around the world have been damaged. And if you don't have very much money in a government health budget, and then you get hit hard and have to make cuts, then if the cuts are in healthcare and then with diabetes care, you can imagine what could happen. So we're very concerned about what will happen in the future, and we're keeping a close eye on it. In Uganda, we did a survey where there was a lot more problem with insulin, with accessing insulin, with accessing syringes, and with blood glucose testing once COVID hit. And this was actually in a district which was pretty organized. And there was a lot more missed injections, missed blood glucose tests, and missed meals amongst these 50 young people that we surveyed. And there were lots of individual impacts. Again, in Uganda, one of the young people had trouble getting through a roundabout to get their supplies. They got bashed up a bit by the security forces before people realized it was okay. In Bangladesh and in Tanzania, we've had reports of young people dying because they couldn't, because of the transport problems, they couldn't get access to care when they had a DKA episode. And most disturbingly of all, 2 young people in Liberia died with COVID, with documented COVID itself, and probably another young person in Tanzania. We've had, this has really hit centers badly, centers that cross finance, what I call Robin Hood centers, where they make money from the rich and help the poor, but the rich haven't been coming for care. No one's been going out. And so the incomes of these places have crashed, and they're struggling to keep on going. And there's lots of reports of staff continuing to work without payment as no funds are coming in. So we've sent over $260,000 to date to partner centers in 17 countries and very specific targeted grants. This money's come from the Helmsley Trust, from JDRF and Direct Relief, and individual donors. And you can see we sent this for the clinic, for funds, for food, for staffing, for PPE and COVID testing, for local insulin purchase, and for insulin shipments. We had a huge shipment of insulin for over 3,000 young people stuck in Frankfurt Airport for weeks because we didn't have, there was no planes flying into Ethiopia. And if you're going to have insulin stuck and needing a refrigerator, then for it to be stuck in Germany is probably the best option. They're good at refrigeration over there. But it took us an extra $10,000 to finally find a plane to get it down. But then it was, and it was distributed. And some amazing pictures have come through. In Sri Lanka, the government centers were running out of insulin. So the Diabetes Association said, well, we need to help. And 2 young volunteers with type 1 got into cars and motorbikes, which I'll show you in a sec, and with police permission, went all over the country to deliver insulin. This is at the peak of the lockdown in around April. And there they are on their motorbike, getting the supplies around. And this undoubtedly saved lives. Another young fellow I think he's a bit bemused by the whole thing. Should I be a spaceman or what's going on? In Guatemala and in India, again, the volunteers went out helping distribute supplies, getting permission. And I think this is my favorite photo of the year. This is from Kota in India. So this is the son of the doctor there. And Puneet is about 17 or 19 now. He's been receiving support for a long time. He was a young diagnosis from this center, supported by Life for a Child, and he ran out of supplies. And so the doctor's son got permission from the authorities to go through one barricade, and then permission to go through a second one. And then here he is handing over the supplies through the barricade under the watchful eye of the guard. And we've done a lot of thought. If we're going to try and improve care, we've done a lot of thought into how to define an intermediate level of care which is cost effective. Because, and this is the paper that we published on this a couple of years ago, you know, in Australia or America, you can get comprehensive care. You can have your analogs and your pumps and your CGMs, and you get good diabetes education, and you can achieve great outcomes and live a normal, long life. But in many of these countries, as I've described, it's only minimal care. There's enough insulin to stay alive, but almost no blood glucose monitoring, as you've heard from the stories that I've shared. And these kids die quickly, or they get very sick with complications in the early adult years. So what we're promoting is intermediate care with human insulin on a basal bolus regimen, blood glucose testing, and probably most critical is good diabetes education. And with that, you can achieve good outcomes. And we've shown this. So this is the intermediate care that I just mentioned. And we did some modeling work with the University of Pittsburgh. And I know there's a lot of this is a complicated graph, but just look at blindness and renal failure here. Two things you really don't want to have. Blindness in green, renal failure in blue. And this is over 30 years. And what it shows, if we can move the A1C down from these numbers, you can see, say 12.5%, you can see that about half of the young people are going blind or developing renal failure, and they'll likely die because they won't be able to access dialysis. If we can move that A1C even down to 8.5%, which is still above target, you can virtually eliminate blindness and these most serious complications. And so that's what we're heading. And of course, if they can get down lower, you can, it's even better. And not surprisingly, when you do this, when you model this out, the mortality improves, and not surprisingly as well, it is cost effective. And we've shown so this is the US T1D exchange data. So you have age in years here, and you have the average A1C at that age, and there's always a peak in the teenage years because of hormones, and we've all been teenagers, and you're working out your life and all sorts of things, ups and downs and everything. So the A1C goes up in the teenage years, then it falls on the whole, not in everyone. But in Bolivia and Mexico, we've shown that our clinics, the clinics we support, are achieving quite similar results. Now, some of the other countries we help are higher than this, but it's so encouraging that even with intermediate care, you can achieve good results with dedicated doctors and nurses and families. So we carefully monitor the A1C in the clinics that we support, with the aim to move them all down to the left with time. This has just been published just this weekend, actually, in the Lancet Commission on Diabetes. And this is some modeling work that we did where we modeled that if you can improve care to comprehensive care across the world, you could save 12,000 deaths in children and youth, and 8,000 if you moved even just to intermediate care. So this is the numbers that we estimate are dying. Young people with diabetes will occasionally pass away for reasons, even high-income countries for reasons connected with diabetes and other reasons. But you can. There's a lot of unneeded deaths happening at the moment, terrible deaths that could be averted by going to intermediate care, and even more to comprehensive care. And not surprisingly, most of these avertible deaths are in Africa and South Asia. We also look at incidence. Incidence is the rate of new cases. And one of the extraordinary things about diabetes is how much this varies around the world. Finland, as probably many of you know, has the highest incidence in the world. The USA is in here with a high incidence. But some countries, it's very uncommon. And sometimes this is lack of diagnosis, but sometimes it just is very uncommon. And understanding what the incidence is in a particular country is critical, because if you don't know the numbers, how do you arrange care? And so, and we also know that incidence has been increasing in many countries by about 3% over the years. And this appears to be tailing off now in at least non-Hispanic white populations in America. It appears to be tailing off in Finland as well. But in some countries, it's still going up. In most countries, it's still going up. And in some countries, it's going up by more than 3%. And again, we don't fully understand why. If you can work this one out, you'll get a Nobel Prize. So go for it and help us all and tell us all. And there's lots of places where we don't know the incidence. Any country that isn't isn't colored pale, very pale gray like Australia or USA, we don't know the incidence, or the data is very old and there's lots of gaps to fill in. So we've been filling that in with many partners. And we have studies in a number of different countries happening. There's more that could be added to this list now. And this is data from the Maldives in the Indian Ocean. And you can see that they had a 12% annualized increase over 10 years. And this is data that we've analyzed a couple of weeks ago from Eritrea. And you can see the age of this. So this is 0 to 4 years, 5 to 9, 10 to 14. In Australia or America, the peak is around here. The peak is around 10 to 12 years. And so usually this number will be the highest. In Africa, there's two very interesting things happening with this information. Firstly, the age of onset is later, and I won't go into the reasons for that, but we can speculate why that might be so. But most importantly, we already knew that families from the Horn of Africa, from Eritrea and Somalia, if they moved to Minneapolis or Seattle or Paris or Sweden or Melbourne or wherever, there's various reports that they had a high incidence, higher even than the people in the children from those countries. And these incidences of 50 and 46 are actually the highest reported anywhere in the world for that age group. You know, Finland peaks at 60 here, and that's the only one really that's comparable. And so knowing this information is critical so that you can provide care. Eritrea is a small country, but there's a lot of children and young people there with diabetes. And this is data from Bangladesh, which, like with the African data, shows that the average age of onset is more in the teenage years than in the pre-teens years. Example of a country where we help is Mali, where in 1999, 18 of 20 children with type 1 diabetes died within 3 years. And the numbers have grown since 2007 from around 14 to over 600 now. And this is the diagnoses that are happening. And some of this is the increase in incidence that I was talking about. Some of it's just better recognition. And this jump between 2013 and 2014 was, we think, due to this campaign that we did, which was in health centers around the country about type 1 diabetes, and essentially more cases are being picked up. And we think there's still cases there that are dying undiagnosed, but less than there were before. And this is the prevalence, the number of existing cases, and not surprisingly, that is screaming up as well. So how can you help? And many of you do, and I'd like to thank you. You can spread the word and follow us on Facebook and Instagram. If you're in a position to donate, you can help that way, and you can fundraise as well if you like. And a one-off donation or a regular donation, e.g. $1 a day, can help a number of people at present, given the support that we have from companies. $1 a day over a year can support the care for 2 or 3 children, which is for a year, which is pretty amazing. It's very cost efficient if you're able to help that way, and we'd be delighted if you can. We've had young people from around the world do all sorts of innovative ideas to raise money and have a lot of fun in the bargain. We've had liftathons and dinners and dances and school fundraisers, marathons, fashion shows, soccer competitions, water slides, kayaking tours, all sorts of bar mitzvahs and bat mitzvahs, all sorts of things that people have done to raise funds and to have fun with their friends. And if you'd like to do that, we'd be delighted and can give you information to help. Another way of doing it, of course, as well is the Spare a Rose campaign, which is coming up. As I said, it peaks on Valentine's Day, and it's run for the first 14 days of February. And finally, to come back to Ray, that 17-year-old boy who almost died, misdiagnosed. This is how he finished his story. He says, "For 9 years, I've been diabetic. For 2 years, I was alive without quality. But for the last 7 years, it's been great. No admission in 7 years is quite an achievement. I still have my whole life ahead of me. I'm a high school graduate about to enter the university. I'm looking towards a great future with good health. And I'm sure that's how you feel as well. And we have a shared vision that no child should die of diabetes. So once again, I'd like to thank you, and I really look forward to interacting with you in questions.
Thank you, Graham. That is an incredible, inspirational story. The work you do is simply amazing. We have a question. Actually, we have two questions. Let me get to those first. So from Bastian, can you share the study data on the effectiveness of the various cooling systems? At some point, if you can get that, I'll make sure that Bastian gets it, and we'll put it in the recording and write-up of this Screenside Chat, which should be online later this week.
Yeah, simplest thing is to send you the paper we published on that, which has got all the graphs and everything. Yes.
Excellent. So we'll take care of that. And then we have a question. Are you seeing an uptick in type 1 diabetes worldwide related to COVID?
The short answer is we don't think so. There's been some people who think that the new presentations have jumped up. Other people have looked at the data and in their place and said, no, it hasn't. I think the jury's still out on that, but we haven't heard any reports. We have heard a lot of reports of people having trouble accessing care, but I'm not certain about the increase in cases. It may be that it's occurring. We're not sure yet.
Okay, I'm going to post in our chat link the website for the Life for a Child program. And I urge everyone watching this to go visit that, learn more about it. And then, as Graham had mentioned, at the beginning of the year, members of the diabetes online community from around the world undertake a project that we call Spare a Rose to support Life for a Child. And the idea is, on Valentine's Day, save the money for one rose. So buy 11 for your sweetheart, donate the value of that 12th rose, because that value in the US, about $5, is 1 month of life for a child with type 1 diabetes in an under-resourced country. You can find that at sparearose.org, and that will redirect to a page within the Life for a Child website. And I would encourage all of you in the beginning of 2021 to consider joining us in the Spare a Rose effort. We have one more question. Is Life for a Child present in Iran? We've heard some disturbing reports from Iran in the last, I guess, time, particularly with COVID challenges.
Yeah, we're not. I think on the whole, when we've looked into it, the government in Iran does provide insulin and test strips. We did have an email the other day, and well, not the other day, a couple of months ago, from a family there, and we referred them to the Diabetes Association there. I think it's probably has sufficient government support on the whole. I'm sure there's needs there that could be supported, but no, we don't help there.
Very good. Well, Graham, I want to thank you again. I want to thank all of our guests for joining us. We can dismiss a little bit early here. Graham, I know it's very early in Australia for you. Yes. Thank you for getting up and having an early breakfast to share the incredible work of the Life for a Child program. And with that, thank you all for joining us. Our Screenside Chats are going on pause until early January. And in December, we will have our early 2021 roster listed. And you can visit us at cwd.is Screenside to see the next slate coming in mid-December. With that, thank you, Graham, and thank you all for joining us. Bye-bye.
Thank you. Bye-bye.